And welcome everybody. It's good to see some of your faces. I see faces I haven't seen for a long time. Hi Shay. I could say hi to just about everybody on here. Yeah, welcome. And I would like to first of all give a land acknowledgement. And I'd like to begin by acknowledging Indigenous peoples of all lands that we are on today. We reaffirm our commitment and responsibility to care for the lands and to strengthen relationships between nations and to improve our own understandings of local Indigenous peoples, their unique histories, homelands, languages, cultural practices, and spiritual beliefs. From coast to coast, I get choked up these days just even doing land acknowledgement. We acknowledge the ancestral ceded and unceded territories of all Indigenous people that call these lands home. Please join me in a moment of reflection to acknowledge the great harms and mistakes of the past, some of which we are just beginning to know, and to consider how we each, in our own way, move forward in a respectful and meaningful spirit of reconciliation, healing, and collaboration. So let's just pause for a minute here and think on that. So it is my very great honor to introduce Dr. Jennifer Charlesworth to you all. And I'll just tell you a little bit about her. She is British Columbia's representative for children and youth. Jennifer has worked in the BC social and healthcare sector since 1977 in frontline child welfare, social policy, program management, and in executive roles. She was engaged in formative work on deinstitutionalization and community inclusion for people with disabilities, women's and girls' health, mental health, and youth services. As part of her extensive background in the services of children, Jennifer has taught child and youth care at the University of Victoria. She has been the executive director of the Federation of Community Social Services of BC, and she is the founder of the Leadership 2020 program for the Federation. Jennifer has also worked with many Indigenous leaders to inspire culturally safe workplaces for Indigenous staff and the people with whom they work. Jennifer has a PhD in child and youth care from the University of Victoria and an MBA from Oxford Brookes University in Oxford, England. And she is the parent of two vibrant young adults who remind her daily of the power and promise of young people. So, Jennifer Charlesworth, Doctor, please join us. You're here and we're just delighted.
Thank you so much. Thank you. And thank you for that beautiful acknowledgement of the lands and also an opportunity for us all to reflect on this time and what we're being called in to do as a society. It's also nice to see some familiar names. So thank you for the invitation. And I'd like to acknowledge that I am on the traditional and unceded territories of the Saanich people in the area also known as Saanich. And very grateful, especially these days, for the keepers of these lands from time immemorial and how I've been held by these lands over this last 15 months in particular. So it's an honor to be with you today. And I want to start by acknowledging too that this is what we're going to talk about is difficult. There are no simple solutions. And I also acknowledge that each one of you have your own stories and your own reasons for being here today. So want to create some space for sharing your perspectives, your views, your experience and insights. Your stories are important, and I'm only as strong as the circle of people that are providing me with information and perspectives as we wrestle with some of the most complex social problems that we are facing. And substance use, and particularly the toxicity of the drug supply right now, is a huge social issue. It has many, many layers, as you all know. Mental health and addictions is one of my office's top priorities. And today I want to talk about a few things. I want to give you a little bit of an insight into our office, and so you have a better sense of how we've come to know what we know or what it is we are learning. And I have some data. I also want to situate that in the context of what we have said before about the needs for mental health and substance use services in the province, what we have been calling for some time, where we see some progress, where we don't see some progress, and then take a look at Bill 22 and why we've had concerns about it and why my colleagues have had some concerns about it and where we might go going forward. So let me just, I have some slides that I'm going to share with you. And I will stop periodically for some questions as well. So we will have lots of opportunity for dialogue. So let's begin by just wanting to give you a sense of who our office is and what we do. I'm an independent office of the Legislative Assembly, so chosen by all three parties. It has to be unanimous for any one of us to get appointed. So similar to the Ombudsperson, Merit Commissioner, Conflict of Interest Commissioner, Human Rights Commissioner, etc. So there's about 7 of us. And I report directly to the Legislative Assembly. So it is not something that I go through a government ministry. We have 3 legislative mandates. One is advocacy. So we assist children, youth, and young adults, and I'll come back to that in a few moments, who need help dealing with government and government services to address some of the concerns that they're dealing with in their lives. We take from that individual advocacy and we identify systemic issues, things that are recurring, things that become patterns that we feel are necessary to address with government and with the systems of care. The next big part of our work is we receive reports from any child injury or death, child or youth injury or death, where the child has had some interaction with the care system in the last year. So they might have been they might be in care, but many times they're trying to access mental health services. And so those reports come to us, and a critical injury is where there's been something that's life-altering. So an overdose event is a critical injury. We review that as a critical concern. Or increasingly, we are getting reports from children who have lost their loved ones, their parents, their siblings, their aunties, uncles, grandparents. And we see that as a life-altering injury as well. We code that under emotional harm. So again, to give you a sense, we get between 350 and 400 of those reports every month. About 180 to 200 of those meet our threshold, pretty high threshold of a life-altering injury. And we review each one of those and we, again, see what's going on here. Sometimes we'll raise it as a case of concern with government. Somebody needs to do something. Sometimes we will advocate for that young person or their family. Other times we see patterns and we address those through aggregate reviews and reports. And sometimes we'll take a single story and we'll do an in-depth investigation. So I'll talk a little bit about one of those that I released last week. The third area is we have the responsibility and the opportunity to take a look at the full range of government-funded services where child and youth well-being is a consideration, and we can make recommendations for improvements to government. So any of these areas might manifest themselves in a report to government or in conversations with government, might result in us doing knowledge mobilization, et cetera. So we have quite a broad range of areas that we can work on. And I should say too, all of this is supported by 2 key things. One is, what can we learn from young people and community members, families, that will inform the direction that we go? And also, how do we become more attentive to the experience of First Nations, Métis, Inuit, and urban Indigenous children, youth, and families and their communities? So that wraps around our work, because frankly, the vast majority of children in care, over 2/3, are Indigenous children. And yet they're underrepresented in some of those supportive services like mental health and substance use. They are not getting the kinds of supports that they need. So that's a little bit about what our mandate is and some of the things that come to us. Thousands and thousands of reports that we receive, and thousands of advocacy calls. So it gives us a real insight into what's happening for those children who are arguably the most vulnerable. And I think if we organize and arrange our systems of care to lift those children up, then that's also beneficial to all children and families. So just to give you a sense, we have two kinds of areas of scope. With our reviews and investigations, that's up to the age of 19, but our advocacy work extends into young adulthood now and will continue to be enriched. So right now we can advocate for children up to the age of, young people up to the age of 20 and inclusive of 23. That's for community living, young people who've been in care and are on agreements, or are trying to access post-secondary. Kind of narrow, but what we're anticipating in the next year is that will increase up to age 27, and we'll be able to advocate for mental health and addiction services and supports up to that age of 27. So that might capture a number of the young people that you care about or the people that you are concerned about. So I'm hopeful for that. It was recommended a number of years ago, and we're waiting for that to change. Because what we know is that brain development and development of a young person, they're just not ready to be kind of cast adrift at 19. And the adult service systems, especially in mental health and addictions, were designed with chronicity in mind, like long-term mental health concerns, not for, or substance use, not for the kinds of things that are showing up amongst the young adult population. So that's something in the future. So it just gives you a sense of who we are. I'm going to share some data with you. Hopefully that's going to give you a sense of some of the things that we see. And the first is what we receive reports of accidental overdose. And remember, this is just a slice of the people that we are concerned about writ large, but this is for young people that are somehow involved in the systems of care right now. So what you'll see here is this is over a 3-year period. So for this is deaths by accidental overdose in the under 19 population. And so we've got the proportion of young people for non-Indigenous, and you can see what we see for non-Indigenous is most of the young people who pass actually are not in care. It shifts with First Nations or Indigenous children, First Nations children. Many of those children are in care. And then a very small percentage are Métis, and those are not in care. They're living in the family home. So it gives you a sense of what the kind of balance is in care and indigeneity. So here is the number of deaths, and then this takes a look at who's involved already in their lives. So for many of these young people, their families are trying to get them connected to services and supports. And so Child and Family Services, of the children who've passed away, 34 were involved in Child and Family Services, and sometimes we code these, there might be 2 or 3 services being provided, but you can see that mental health, youth justice, the health authority and the mental health services, addiction services, and children and youth with support needs. So the vast majority, there are kids that are involved in the Child and Family Services system, which might be family supports all the way through to being in care. So it gives you a sense that there are young people that we're connected to, but we wonder about, is this sufficient? Is it making a difference? So gives you a sense there. And okay. And overall, I just want to situate substance-related harms in the notion of all kinds of injuries that we see. So this is what we see. The vast majority of injuries that are coming to us are what we call emotional harm. And in that, I would say about a third of those are children who have lost their loved ones to substance or mental health concerns. So lost their loved ones to overdose or suicide or in some cases, there are some physical illnesses, but it's a huge challenge, and it's often not spoken of because we talk about the person who passes, or the child, or the young person who passes, but we don't talk about the circles around them, their families, the people who love them, and the impact on those people who love them. And we must not forget about the impact of the toxic drug supply on children. And these are, 3, 4, 5, up to, 12, 15, 18-year-olds who are losing people that are important to them. And again, we have certain stereotypes. We've got to remember that we are losing adults who are parents, who are aunties and uncles, and who have people who love them and for whom they also love these young, these children. So I think that's an important part to note, is that this is a life-altering experience for people who are left behind as well. And then you'll see over here, substance-related harm. So this is where a young person has experienced an overdose event. And this is dramatically underreported in our view, because oftentimes what will happen is we'll see, a worker might do a report, and they might do one report for an overdose event, but then as we start to look into the file, we see, well, actually they've had 3 overdoses in the last month, and all of which has brought them to to somebody's attention. But oftentimes they're treated with naloxone in their group home or by a friend, and we don't get the full extent of the depth of the harm related to substances. So that's something to bear in mind, as well, as we think that it is quite underreported. But you can see that these are very serious experiences that young people have. And oftentimes we see an intersection between, for example, substance-related harm and suicide attempt, or emotional harm. Something traumatic has happened to the young person, and substances as their ways of coping. We see a huge intersection between sexualized violence or assault and substance-related harm, particularly for girls as well. So let me just, I've got to catch up to my notes here. Okay. Yes, and just to give you a sense of some of the intersections that we see is as I mentioned, we're seeing a very strong correlation between sexual violence and substance-related harm, and where the dealers are grooming young people or are engaging young people in things that are very harmful to them. And it's really hard to pull away the pieces, what's the substance-related, what's mental health, what's happening as a result of their trauma. So we're seeing that particularly in the downtown east side and the Surrey Wally area, but also throughout the province. And we're seeing a younger and younger population. So 11 and 12-year-olds, it's not uncommon for us to see 11 and 12-year-olds that are in this constellation, and for whom they are starting to experience substance-related injuries. And of course, we have a very high-profile death of a 12-year-old recently. So just in the past year, for example, we've had 3 files where young girls around 11 to 12 years old were removed from a parent due to protection concerns, placed in foster care, and then those placements broke down, and then young people found belonging in the street, living and working on the street. So it's a pretty significant concern that we have. It's never ever one thing. We often see children around the ages of 11, 12, or 13 that are struggling with, transitions to a new school, maybe family breakdown, contentious family law situation. They're just really struggling. And the parents often know, they're asking for help. They're starting to see that something's going on, and yet there's really nothing for them to support the family in their journey of healing and prevention. So okay, so the one thing that we're curious about is we actually have seen a reduction in the number of substance-related injuries over this last year. We're not entirely sure what's happening, so this kind of gives you month by month of what we're seeing, but we think that it's in large part because there are some improvements in terms of naloxone is much more readily available. More young people are using it with their friends, and there's a dramatic underreporting. So we're not entirely sure what all that means, but we're trying to better understand it. So I've mentioned earlier, we take a look at who's in care, and of those injuries, a lot of the young people are in care, but not all. Over a third, or around a third, are living with family and experiencing the challenges, and the families often are really trying hard to find some support. Just to give you a sense, in the non-Indigenous population, it's equally likely to have male or female, which is intriguing when you start to think of, as the coroner's stats would suggest, that there are more males that are experiencing death, but in terms of injuries, we're seeing pretty similar amounts of boys and girls. And yeah, this just gives you a sense of where are they living. Many times they are living in resources, and yet resources are really struggling to try and keep them safe, but many are connected to their family home. So last week I released a report. So it gives you some sense of some of our data. And again, we're happy to share these slides with you, but maybe I'll just stop there before I move on to see if there are questions or things that you're curious about. Oop. I don't know what that is. Somebody else is showing their screen. So if you want to stop doing whoever has that, looks like Marvin Roberts' screen. Let's just see if we can close that off. Okay, well, maybe what I'll do, there we go, thank you. So any questions in terms of some of the background information? And again, this is a lens in, but it gives you a sense of what teaches us about the concerns that of the toxic drug supply and the impact on children. Yeah.
Hi, Jennifer. There were a few questions in the chat during your presentation. Okay. One participant asked if these statistics are available for public circulation.
Yep, we're happy to share these slides.
Great. And then another is the overdose data only when they're out of program or just on site. I'm not sure what that means. That was from Shay.
Yeah, help me understand that, Shay. I want to be able to answer your question.
I assume you have programs, so either group homes or foster care, that are reporting data. Do you have data on overdose or activities that are happening when the kids are AWOL or out of program or missing?
Yes, yes, we are supposed to receive reports when a young person, regardless of where a young person is living. But Shay, you can appreciate that sometimes that happens and sometimes it doesn't. The other thing that I should say is, despite the fact that the health authorities are supposed to provide us with reports, the health authorities have, and that's in our legislation, we've never received reports from the health authorities. So if, for example, a young person overdoses in hospital, which has happened, we don't receive reports, so that's another reason for the underreporting. But we are supposed to receive the overdose or the reports regardless of where they are. Sometimes what happens, though, is that the young person might be, well, they might be away from their program, or they might be living in a shelter, or not be connected to a placement, and we don't know about that. So, but it is supposed to be reported to us as soon as the worker finds out. Does that answer your question?
Yeah. And then, so I have some experience, but it's Albertan. So has there been explicit instruction to the service providers that they should have naloxone on site? Their staff should be able to use it at any time.
Yes, yes, absolutely. And it's an interesting point, because one of the things that we've been curious about is that although that's an expectation, what we're not sure about is whether that has actually been followed up on, and particularly for foster homes. So that is a concern that we have, but the expectation is that staff, especially in residential care, would have an understanding about using naloxone and be able to discern when that would be called for and necessary.
Great.
So let's see, Glenn, not enough data nor time to draw conclusions as to trend, better to draw the error boundaries. Glenn, do you want to?
That wasn't a question. I prefaced
Okay.
my questions with questions.
Okay.
So the question, the related question would be, how do you see government receiving and then processing this data, which
Yeah.
in my mind is rather shocking.
Yes. Well, I'll maybe we'll come back to that, Glenn, because I'm going to talk about some of the reports that we have released, and I'll talk about the government's response to that, and that might be helpful. So hold on to that thought. And Shay, you asked the question, is the data inclusive of gender diverse youth or just the binary? We actually do code for gender diverse youth. And interestingly, what we see is quite a different pattern. We're not seeing, we see the greatest risk for gender diverse youth through our work is suicide ideation and suicide attempts. And if there were gender diverse youth that we had an overdose event with that was recorded, then that would have shown up in our data as well. So we do try and capture the non-binary. So, yeah.
And we have a question from Diane McNally. What exactly is living in resources? Which resources?
Yes.
Yeah.
Okay, great question. Thank you for that. So what we mean by resources is typically what many people know as group homes. So they are typically staffed residential placements run by community agencies or maybe experienced foster caregivers. So most of us would know them more as group homes, but they are referred to as resources now. We don't see many young people any longer placed in hotels. Sometimes that happens, but that's in situations where there's simply no resource available. We were just having a conversation about that this morning, that sometimes in certain areas of the province, we're seeing a huge challenge or a lack of supports, resources, placements, foster homes, you name it. And sometimes they have to get creative and shelter or safe homes or hotels are provided, but that's not ideal. You know, a safe home or a shelter is not a placement, is not a home. It's a temporary placement. But if that was the case, then we would also receive reports from there. So that's what it means by resources. Think group homes primarily.
Great.
Yes. Oh, Jan, yes, I think I answered that. Do you get reports from health authority death reviews involving failure of mental health services causing overdose death? No, we don't. We've been working with the health authorities over the last over 2 years. It predates me. It was my predecessor that began that work. We're just starting to get reports from the health authorities, starting with Vancouver Coastal, and then it will roll out over the next year with the other health authorities. That's something that we're very concerned about, because I think there's a huge missed opportunity if we don't understand what's happening in hospital-based care or in health authority care. And that intersection of, if I understand correctly, that intersection of mental health services and overdose experiences is very closely linked, and as many of you will probably have the lived experience of, what we see in our system is it's not very good at dealing with the co-occurring conditions. Sometimes we hear stories of, you know, a child with significant mental health concerns presenting and needing mental health care, and then the service provider says, well, we can't help you because you've got a substance use problem. Go deal with that, and then we'll deal with mental health, or vice versa. So I think that's a huge challenge for us, is we have to get better at understanding the whole child and what's going on in their life, or the whole young person and what's going on in their life. Because it's never simple. And as I was meeting with a parent last night who lost their child, and as she said, you know, one of the things that the system has so much stigma and shame attached to it too, that when young people present or when the family presents, there's just this cloud of judgment that they're often experiencing within the system. Well, that's hugely problematic. And in fact, speaking with physicians this morning and through a report that we did on mental health care and involuntary detention, that sense of the overlay of shame and stigma and blame, or, you know, it's a choice. It's not a choice. It's not a choice. It's just, yeah. So, yes. So Diane, let me just capture a few more of these. And then how can we be confident in describing the deaths as accidental overdose and not suicide? Yes, yes. That's a big challenge for us, Diane. So just for those of you, so how can we be confident in describing the deaths as accidental overdose and not suicide as a way out of desperation, lack of meaning in life, past and ongoing trauma? We don't know. We don't know. We're doing our best as we take a look at the story and what's going on, to see what some of the indicators are. But we don't know for sure in many cases. But I think your point of what we do see is young people who, and I'll talk about this when I talk about Skye, who don't have a sense, there's a lot going on in their lives, and the use of substance is a coping mechanism. It's actually something either because they've had physical harm, like they've experienced physical injury and they're trying to cope, or they've had emotional harm. And we do see that that's kind of it's so intertwined, right? That the experience that young people have, substances is a way of coping. It's a strategy. And as one of our report, when the young people said, yes, you know, it's the way I cope with my pain and emotional harm. It's because I want to be numb to the pain that I'm experiencing. So definitely hard to discern. But we also try and figure out what's the language that we could use that would be the least stigmatizing as we go forward. So always need help with that. So I look forward to our conversation. And we are still getting pushback from different school districts about even having naloxone on site in school facilities. Is this a concern of your office, and is it something that you can put forth a recommendation? Whew. Great, Tracy, thank you for raising that. I'm curious and I would like to learn more. Certainly we have seen situations in which, as Dr. Martin Brokenlake talks about it, that in our education system, it's doing a lot to create unbelonging. You know, they're so anxious about the young person who might be using that, you know, they very quickly will kick them out. And then that creates further escalation of harm. So I haven't heard about different school districts not saying that they're not going to have naloxone on site, but if we can have an off, you know, I'd like to learn more or also have some more insight, we can chat later as well, because that's absolutely something I would bring up with education and with the principals and vice principals and the superintendent, no question whatsoever.
Great. Thank you. We have one more question there that popped in, or if you have time. Yeah.
Are there statistics or research in BC on the relationship between substance use and interactions with police incarceration for young people? Yes. The Cedar Project. So it's, we haven't got statistics or research. Interestingly, we tried to take a look at that when we did our report on the involuntary detention under the Mental Health Act. And the stories we were hearing from young people was that they often had interactions with the police, and they were often very harmful interactions. You know, they were put in the back with handcuffs, or, you know, or they were having an acute episode, or and so one young person I remember saying, You know, here I was in emergency, I was handcuffed and there was a big cop sitting beside me in emergency. And he said, I just felt like I wanted to shrivel up and disappear. So we actually asked for, we tried to find information, and no one's collecting data. So one of the recommendations we made in our detained report, because Mental Health Act is being used right now, even though it's not supposed to be, is being used to address substance use issues right now. And what we tried to do was find out through the police, through the health authorities, for example, you know, who's bringing these children in? Is it the police? We got a little bit of data, but we don't have enough to really see what the patterns are. We don't even have data on the number of Indigenous children that are presenting themselves at hospitals. So it's really hard to know what's the scope of the issue there. We have a huge data problem to really understand the scope of the issues. So Cedar Project collected some data exactly, and that, so it's not tracked provincially, but the Cedar Project has certainly opened our eyes to some of the questions that we need to continue to ask and see if we can gather information. So hopefully that. Yes, and how about, I will move on now. So the detained report, I will bring that up and share more with you about that. And all of our reports are publicly available. So last week I released a report. This is a young Indigenous girl who died of an accidental overdose. And this is a report that it was the first one I chose from the very beginning to do an in-depth review on. And it's one that we shed a lot of tears and continue to feel quite emotional about. So you'll hear that in my voice because it's her story as many children's stories. And it just continues to break my heart to hear from families and from young people about what they're dealing with. So Skye was a very bright young First Nations woman who was in government care from the age of 5. She was, it was beautiful when we do our investigations. We try and understand who this child is, and she was described as sparkly, bubbly, had her own mind. She loved being outdoors. Fishing was her zen, is what was described. And she was known as the mother hen because of the way in which she took care of others, but she faced tremendous trauma over and over, and she was put into care ostensibly for protection reasons, but she never saw her mom again. But what's important about this is her mom, who's in the middle there, also experienced the same kind of challenges in her life. And her grandmother, which is over here on the left, also experienced the same kinds of challenges. So it really spoke to us about intergenerational and historical trauma. And they all wanted to connect with one another. They all wanted to have a sense of connection, but the system unfortunately was not prepared or able to do that. And there was a tremendous amount of shame and judgment directed towards the mom because in order to deal with her trauma, she used substances. She tried very hard many times to heal and to be well, but unfortunately, I think the way in which she was responded to, it prevented her from being whole. So this is Skye at different ages with her mama when she was about 3, about 5, 7, and here she is about 12 or 13. So it gives you a sense of this beautiful spirit. She taught us a lot. She was moved 15 times. She lived in 8 different foster homes. She attended 8 schools, and she had 18 different social workers in 12 years. She had 3 failed adoption plans. She was disconnected from her culture and her family, and she struggled with her own mental health. And she wasn't provided opportunity to connect with her Dene culture in any meaningful way. And despite the fact that she wanted to go up to her community, which is near Fort McPherson in the Northwest Territories, and in fact doing her own research. She was very clever. She tracked down family members. She knew about her community and she asked to go, but she never had the opportunity to do so. And so she did start to use substances at a fairly young age, starting with alcohol, and then moved on from that. And all sorts of things happened to her. We actually didn't put a lot of that in the report because we were trying to do the report in such a way that we didn't want the focus to be on all the horrible things that had happened to her, but recognizing what the missed opportunities were. And so she died at 17, and you know, polysubstance user, many of the things that were that we've heard in many situations, especially for our young people. So we chose to work with Skye because her story, while uniquely hers, is actually many young people's stories, young adults and youth as well. So lots of things going on in their lives. It's never just one thing. And it's, as I said before, it's never a choice. So complex problems don't lend themselves to simple solutions. And that's a key thing, because I think when we start to talk about Bill 22, it's like, is this a simple solution for a complex problem? I think we need to be more nuanced than that. So Skye's story is illustrated over and over by our advocacy calls as well, and all of the different ways in which kids can fall through the cracks. So, for example, we've heard over this last year in particular that young people are not able to get the supports that they need, and they're finding themselves in shelters, sometimes harbored by older adults in the single room occupancy hotels. For example, we are seeing young people starting to use it younger and younger ages. And we're starting to, we frequently hear from parents saying, I have tried everything that I can think of, and there's simply nothing for us. Or we're put on a wait list and it's 3, 4, 5 months, and I'm watching my child really struggle. So, and parents know, they can see what's going on, or foster caregivers know, or people who love that child know, can see what's going on, and there's just very little available for them. So there are some specialized programs, but there are also long wait lists. And typically when a young person is ready for treatment, there's nothing available. They're put on a long wait list. And for youth in smaller communities or rural communities, there's virtually nothing for them. And families tell us over and over again that if they can find something, it's often short-term and simply not sufficient. So we've heard of families doing just extraordinary things to try and find services outside of British Columbia. So that's really, really concerning. There's basically no long-term treatment. So that's one thing that we see. And, oh, where's my, here we go. So we did release a report actually on substance use and the services in BC last year. And what we found was that the system is complicated to navigate. Information about services is hard to come by. Youth-specific services are very limited, and there are not enough culturally safe and appropriate services. So we put that forward. We did not have recommendations particular to that because we'd already made recommendations from previous reports and wanted them to say, here's the snapshot, here's what you need to know about the service arrays in British Columbia, and we have to do better. So we just pointed out all the gaps in the services that were there. So that, and then, let's see. Yeah, so that's what we also said is complex problems don't lend themselves to simple solutions. So COVID has also affected young people in a very profound way as well, because as we all know, the lockdown resulted in people enhanced stressors, increased toxicity in the drug supply, people using alone, and of course significant risks. And the outreach capacity and the support systems within community vastly vastly reduced. So we have found some real connections between the experiences associated with COVID and their rising mental health concerns. We've reported out on that. And then conversely, we've had some real concerns about the impact in terms of substance use as well. And we've seen that in the numbers through the coroner. So just before I go into Bill 22, I want to share a couple of examples with you today that should give you a sense of what we're seeing. I think it's important, as heartbreaking as this is, that we tell the truth into our service delivery systems and understand what's going on. So they illustrate just how complicated it is, which is again why I have some concerns about Bill 22. So the first example is a 16-year-old boy named Casey, and he was removed from his parents' care during early childhood. There was lots going on in his life: domestic violence, poverty, parental substance use, etc. And since coming into care, he's been in 10 different placements. So a lot of turmoil in his life. He was moved out of his home community and lost touch with his extended family. And we received a number of critical injury reports to him that are related to suicide attempts and substance-related injuries and sexual assaults. So that kind of co-occurring, as we talked about before. And although he disclosed the sexual assaults and reported them to the police, there was criminal action against the perpetrators, and he testified in court, which took tremendous courage. This had a major impact on him because it was so difficult to come forward and to share that information, but ultimately the perpetrators got off. So he just felt like, there's nothing I can do. This is hopeless. I'm not being taken seriously. So it further added to his sense of unfairness, injustice, and isolation. So he did complete intake for mental health services, child and youth mental health, but he struggled to show up to the appointments. 9 o'clock on a Thursday morning, some of our kids just aren't able to do that. And so because he missed a couple of appointments, his referral was canceled, so he didn't get the mental health care. And he also said to his worker, look, I want to work with an outreach worker. I don't want to come to an office for counseling. I want to work with somebody who's out in the community. But there weren't those kinds of services and supports available. So the file was closed, nothing was offered despite him asking for it. So he was in a group home or a resource, and he went missing. And then 2 days later, he was found unresponsive, and he was taken to hospital, treated for the accidental overdose, and then just sent back to his group home. But his group home didn't have any more resources to support him than they had before this happened, and he didn't have any of the supports that he was actually asking for. So another one is 15-year-old Alice, who again had some struggles as a young child and what was going on in her family. But what has been happening for her more recently is she's become gang involved. We're seeing that increasingly for girls, actually. She's been sexually exploited. She's often missing from her placement, and she's using substances. So she hasn't been able to attend school for a couple of years. And but more recently, her cousin died by overdose, and that's another triggering event for many of our children. That loss and the grief that young people are experiencing. Their friends are struggling, their family members are struggling. So now she's described as withdrawn, and she says she feels calmer when she's using substances. And what ended up happening is she was feeling, she was really struggling. She went for mental health services, but again, what happened was because she was using substances, she was referred to addiction services and they closed the mental health file. So she happens to be Indigenous, and she asked, many of our young people know what they need. She asked for more culturally relevant supports, but her care team went for more of the medical model. And she doesn't want that. She doesn't relate to it. She wants something that's more akin to the holistic. As I say, she knows what she wants, and what's available to her is not culturally attuned. She was offered Suboxone, but she declined. And in the last couple of months, we've received 4 critical injury reports for her related to substance use. And in each case, her friends have administered naloxone, but Alex has refused to go to hospital. She's just very anxious about what's going to happen to her in hospital. And as an Indigenous young person, she has good reasons to be concerned about that. So we're pretty sure that there are other some overdoses, but she isn't telling her care team. And thank goodness she's got other people around her that are kind of looking out for one another. And as you can appreciate, these are, we're protecting the confidentiality of these children by adding in some other details so that you can't, that it anonymizes it a little bit, but it gives you a sense of the kinds of things that we're seeing every month. So if we're going to, these stories, as Skye's story does, illuminates a critical truth that we must pay attention to if we're to make any progress in the overdose crisis. And we have to realize that each and every young person who's misusing substances is facing multiple challenges. What we often say, they have co-occurring conditions, but what we're really saying is they've often got a lot going on in their lives. They might be trying to handle the stressors of a complicated life or a lot of their history or trauma, or they might be simply trying to figure out how to grow into their young adulthood. And it's just been a real struggle for them because of things that have happened. So these lives are anything but simple. And so simple solutions are simply not going to work for them. And we also, I think it illustrates so clearly that what we need is a robust array of voluntary services and supports, because young people will need different kinds of services and supports at different points in their journey. And we need it to be accessible, not something that you have to wait 4 months to gain access to. So that's the big thing that we've been saying all along, is we don't have a system of care for children, youth, families, young adults, and adults that would address the fundamental issues that we're talking about with respect to substance use in this province. So I'm going to just stop there before we go into Bill 22. Any other questions? Let me just see. I can't see the chat while I'm got these screens open. So let's just see what we've got on the side here. Yep, we'll come back to the detention.
I think we're back to Diane McNally. Who should we go after for the 18 different social workers? Let alone the rest of the failures to help Skye with any good effect.
Yeah.
Your thoughts on that?
Yes. So one of the things about Skye report, and we see this over and over again, it's never one person, one policy, one program that has created the conditions in which a child or a young person is not being well served. It's really a systems issue. So I think that's what we need to keep reinforcing, is that we have to have a system of care. What we have right now is a bunch of silos and bunkers, as it's been described to me, and overlaid with shame, stigma, blame, racism, etc. That is creating the conditions in which that system of care isn't created, and those supports are not being provided in a good way. So who do we go after? I don't know that there's a who, but more a what that we have to keep pushing on. We need a robust system of voluntary care. And then we can talk about the involuntary in a few moments, but we simply don't have a system. And when we open up for conversation about, what do you want me to know from your own experience? I think that's something I'm really curious about is, was there a system? What are some of the things that we're falling down on? What is working? Where is it working? How do we can amplify or replicate that? But yeah, you're right. We've been saying the same things for over and over again, and it's a system that I think just fundamentally is not designed to put children at the center or young people at the center or those who are vulnerable at the center and plan around them. So it's an inadequate answer for a very important question, Diane. What can we do to help? Okay, we'll come to that one, Glenn. What can we do to help you convince government to be better supporting the needs of children and youth? Here I fear that what is needed is to first stop governments from harming children and youth. So absolutely, I think, and I'll come to that because one of the things we're working on next is actually what do we need to do far in advance of when we're in a situation where a young person is experiencing multiple overdose events? What supports does the family need earlier on? How do we listen and value the perspective of parents and loved ones and caregivers? So I'll come back to that one. Question regarding vulnerable youth 16 and over and older adults. In my experience, there are no laws that can protect a youth after the age of consent when they are being harbored, manipulated, harmed by older adults. You're right. The police, courts, and MCFD cannot do anything. Do you know if there's a possible change in the criminal code around this, or is this something that still needs to be worked on? It's a great question. I know I've had lots of conversations with police chiefs around them feeling that their hands are tied. So it's not something that we've worked actively on because my scope is not at the federal level, unfortunately. So I don't know if there's work on the criminal code, but I know that it's a conversation, particularly amongst the police. It's also something that, for those of you who may not be aware, that the Police Act is being reviewed. There's a select standing committee. And I think it's important that we all consider ways of informing that, because it's not just the Police Act, it's about policing and about the kinds of police are being asked to do things that they never envisioned they were going to be having to do. And they're often at, in a very difficult place. They don't know how to deal with the complexity that they're facing. So I think the one entry point in to talk about what are the tools or resources that are available, that we need to have available. You can bring that forward through the review of Police Act and policing. But your point about, being able to go after the perpetrators or those who are harboring, I can't tell you how many times we see 14-year-old girl, 35-year-old male, and we are feeling completely powerless. And when you take a look at that, these perpetrators know what that child needs. They need a sense of belonging and connection, and they're offering something that our system has not been able to offer them. So, yes, so something that still needs to be worked on. Not convinced that they're misusing substances, suspected managing their pain better than the system can provide. Shay, that's such a, I'm hoping I can save this chat, Leslie and Jenny, because that's such a beautiful way of putting it. I suspect they are managing their pain better than the system can provide, or that the system can help them managing their pain. That's what the young people say to us all the time, is this is my coping strategy. So thank you for that. So Jan, with my son, psychiatry refused to see him when he graduated out of CYMH because he had a history of substance use, even though he had a long history of mental health and had been seeing a youth psychiatrist. Oh, that, Jan, I think if there's one thing that we can find our collective voice on is to push back on a system that is so siloed and is so, that says, oh, well, if you're dealing with mental health concerns, we're not going to deal with your substance use, or if you're, as I said before, it's, and then that transition from a youth to young adult is just like, it's a cliff, right? It's not a cliff, it's a cliff for kids that have been raised in care, but it's a cliff for every child that is trying to access services where they've been receiving supports in one system, and now they've got to navigate this complex, inaccessible system and the adult service system, and again, long wait lists. And so that pains me, but it's, Jan, it's a familiar story. So yes. And Carol, who can blame them for not wanting to go to the hospital? The way substance users are treated is horrific, which just adds more trauma. And absolutely, Carol, that's something that we've been pointing out. And one of the reasons I had concerns about Bill 22 is because we had lots of evidence that young people who were presenting at hospital and being detained were having, it was just exacerbating their trauma. There was an outsized use of seclusion and isolation, for example, and who answers for that? Yeah, voluntary services come and go. Is this, oh, okay. So Diane's question, voluntary services come and go. Is this an adequate goal? Are you meaning peer support? I'm meaning it all, actually. And what I mean by voluntary services is services that the family or the young person or the people who love that young person can access voluntarily at their discretion. So right now, a lot of services are gate kept and you have to go through a referral process, or then we go immediately to the involuntary, like the detention under the Mental Health Act. And what we think is important is that there is a robust, accessible array of services that when the young person says, you know, I think I'm ready to have a conversation with someone about something that happened to me that I'm medicating for, that readiness or that desire of the young person. Or when I talked about Casey, he knew he wanted an outreach worker, but there was nothing available to him. So that's what I mean by voluntary, is that it's at the discretion of the people who are seeking that service, that it's available to them. And I agree, we don't want, you know, kind of the flavor of the month and the voluntary. These need to be ongoing. They need to be available, and they shouldn't be restricted to, oh, your 8 sessions are up, so off you go. And it includes peer support for sure. Yes. And peers are expected to do very heavy lifting in very challenging circumstances for free. Is that sustainable? It's absolutely not sustainable. And I think that what we've been noticing is that peer support work should be well supported and funded and resourced as well. It's unconscionable to me the amount that we are asking those in the front lines to do right now in peer support workers, and thank goodness for them, because they are out there doing extraordinary work. But it is absolutely unreasonable to expect that they would A, do that for free, or B, do it without the kinds of supports and clinical supervision and debriefing and care that they need in order to continue to be able to do the work. Let's come back to this question. Sorry.
Oh,
Sorry,
I was
Jenny.
just, no, I was just going to interject, conscious of time, and I know
Yes.
that we really are anxious to hear your thoughts on Bill 22.
Okay, good.
That would be lovely. And then we can circle back to more questions. That'd be great.
Okay, that sounds good. Let's do that. Okay, so Bill 22. These are great questions. Thank you, folks. So Bill 22, as you know, came forward, continues to be known as Bill 22, even though it died on the order paper and we don't know what's gonna happen next. But when it came forward, there were lots of concerns raised by the coroner, some public, some not so public, Civil Liberties, Union of BC Indian Chiefs, Friendship Centers, myself, Health Justice, Ombudsperson. We all weighed in. And there were a number of concerns that were similar across all of us. And interestingly, I've had conversations with physicians, even those that were trying to push for stabilization care, and they had concerns about the bill and the way in which it was brought forward. So fundamentally, I think it was a flawed piece of legislation, and it took us down a path that was not helpful. So I'll just identify my concerns. As I said, we don't have a system of care. So somebody goes in, they're detained, stabilized for 48 hours, up to 7 days. Then what? They're discharged, and too often what we see, young people are discharged, they're given a taxi chit to go to a shelter or to go home or to whatever, and there isn't, and maybe they've got a referral slip. We hear that from young people. Yeah, they gave me the slip, told me to call a counselor. Like, I threw it in the garbage. So there is no way of wrapping around and helping in those transitions. So in the absence of a system, do you really want to take people's rights away and put them through that? So the next thing that we heard and that I feel strongly about is that, and I know Leslie and Jenny and I have spoken about this, is the most important thing is that people feel connected. And so what we were worried about is that that detention, that involuntary detention, especially if it was seen to be instigated by family members, it would fracture those important relationships. And we don't want young people to ever feel isolated and unable to be connected to family or their community support. So we were worried about the alienation. It just wasn't designed with rights and protections, adequate rights and protections in there, providing access to information, support, mechanisms by which they can come back and ask for a review. So it kind of took away their voice and their agency. And we felt that that was important to address. And the Ombudsman had already spoken about this, as had we. We also noted that there's an outsized use of restraint and seclusion with involuntary detentions, and we felt that they really needed to be some close looking at what was going to happen when a young person was involuntarily detained. Is the intervention, is the kind of supports going to cause harm, or is it going to be appropriate? So that ties into, we felt it really needed to be culturally relevant, trauma aware, and to recognize the impact on Indigenous youth and families. So we spoke to those areas of concern and felt that the legislation as it was drafted was not sufficiently robust and that to do this in a good way and to not cause harm. And to piggyback on the coroner, and it's a concern that I have obviously as well, is that the evidence also suggested that as 48 hours or 7 days, the tolerance went down, and then the risk of an accidental overdose increased with smaller amounts of substance thereafter. And although it hasn't been published, but one of the other jurisdictions in the country, one of my advocate colleagues said that they tracked, because they had secure care legislation, they tracked 50% of the young people who'd been in secure care. Now I know this wasn't secure care, but nonetheless, used within 7 days of, used and had another overdose event within 7 days of being discharged, 50%. So those are not good odds. So we felt like we needed to see what was the evidence, what if they've been doing that, then what is the evaluation, how is this helpful, and how is it that these transitions could be done well. We're not saying there isn't a need, but we're just really worried about how it was going to be played out. And we wanted people to pay attention to the fact that that youth have some insights on what's going on for them and what they needed as well. So we had released a report in November 2018, and a number of the recommendations that were identified there still needed to be addressed. So within this, one of the things that we said was very important was that positive relationships and supports are needed by young people. And when they have those strong connections to the supportive adults or peers, schools, community, and whatnot, then they're more likely to develop healthier coping skills and have improved health and wellness. So we felt that there was some real importance to attend to that. And not one youth has ever told us that involuntary detention would have helped them. So many don't trust the healthcare system as well and are reluctant to ask for help. And this is something the coroner said, is that if friends or the young person knew that they might be detained, then they're less likely to call for help. And that was a huge concern for Lisa Lapointe. Of course, as I've said before, simple solutions for complex problems. Oh, yeah. I want to make sure that I've got, maybe I've just, sorry. The other thing was that, as I mentioned, the detained report. So that took a look at involuntary detention under the Mental Health Act. And what we found there was that young people, by and large, said that it was a traumatic experience and did not help them. So we thought, well, if we've got this kind of evidence, then why would we be layering on another opportunity for youth to be detained? Let's figure out how to do this in a way that wraps around and provides the support and is kind of the warm embrace as opposed to the traumatic experience. And then, of course, the other thing that's so key for us is, so what happens afterwards? Where do they go? What are those kinds of supports? And that was a critical piece that was missing. So, yeah, I'm just trying to think now. Okay. I also wanted to speak finally, and maybe I'll just stop because I want to make sure we've got lots of opportunity for questions. So this last Friday to Sunday, I participated in Adams Lake Indian Band, Walking Our Spirits Home, which honored the survivors of residential schools, and had actually been planned before the Kamloops Disruptment discovery in Kamloops Residential School. And this actually was planned for a walk between Kamloops and Chase. And of course, there was awareness, but the discovery has really shifted, I think, a lot of our thinking. So I think it's really, really important that we understand the impact of involuntary detention on First Nations, Métis, and Inuit and urban Indigenous children and youth, and what that evokes from the experience of the residential schools, from the experience of the 60s scoop. So we, and Les Lane spoke about that in the Times Colonist. He said the words involuntary emergency care, detention, or stabilization, especially when you combine it with in a child's best interest, become even more charged when you think about the discovery in Kamloops. So this is, as I say, I've released that report on Detained about involuntary detentions. And the young people, particularly the Indigenous young people, said that it just really evoked almost that historical trauma that they were experiencing. So these are very strong tools that that we cannot use lightly. And while there may be a need for some children, surely there's more that we can do to support the families and the loved ones and the young people before we perhaps inadvertently estrange them from those very important concerns. So I'm going to just want to make sure we've got time for conversation. So as I said, across the country, I've canvassed all my colleagues at Child Advocates. They all say the same thing, even in jurisdictions with legislation that supports safe care, secure care, or stabilization. They say it's not working because we don't have a system to support young people thereafter. And so Callie, who is a peer support worker in Vancouver, youth use drugs for all kinds of reasons, including staying alive. We need to recognize and honor that. We think we know better than them, but we don't. We have to work with them, not for or against them. So that's, I kind of like to leave it right there. And thank you for your attention. And I know that this is an important conversation and that we need to continue to have. And I think we need to be mobilizing, and I appreciate the questions that people were asking about how do we help one another to surface this so that we actually see the change. So I'm going to turn it over to you, Jenny, and I'll look over here for the questions.
There's a comment from Pamela. Thank you for recognizing the intergenerational loop. Could relatives of the individual in substance use be encouraged to seek treatment as well to better able to connect and support their loved one? This is my story. Wow.
Thank you. Yes, and I think, one of the things that in Skye's story, Skye's mom wanted to go to treatment with her daughter. And the ministry said no. Get this, the ministry said no because they didn't have stable housing for after treatment. And so what we thought was, first of all, how wise of mom to say, I want to go to treatment and I want to do it with my daughter so that we are not separated. This was when Skye was little, she was about 5. And that took courage, right? To say, I need help. And the ministry said no, because she didn't have housing. And I thought, well, shouldn't that be a call to us to say, first of all, family-based treatment matters. I would have loved to have seen Skye as a young woman, a 15, 16-year-old, and her mom go to treatment before her mom died as well, so that they could work through that kind of historic and intergenerational. But for goodness sakes, if the issue is housing, then figure out what's going to happen 3 months from now to make sure that they have housing. If that's going to be the barrier to them finding their way through together, then we've got to figure out how to help that, because it's, you know, it's important. Anyway, so I think that I appreciate the comment that was made. It does require us to think about family as well.
Thanks, Jennifer. We have a comment and question from Dave. Dave, do you want to unmute yourself? Oh, you got it there? We still can't hear you, Dave. Here we go. Oh, somehow you're muted there. Give it one. Somehow it's not quite working, Dave. I'm going to read your comment out. It says, I've seen people young and old benefit from involuntary treatment for both addictions and mental health. Just detaining someone with no long-term treatment, however, is very stupid. Yeah.
Thank you, Dave. Exactly that point. I mean, I think that there may be a place for this. Absolutely. And, but, you know, think about it in context. What's going on that's giving rise to this? How do we be helped? How do we see the whole person? And how do we see the before and the after as well?
Thank you. More comments that involuntary treatment is inhumane. And is it Nitha, if I've said that correctly? Are there ways to reach out to you? Are you willing to be contacted for any questions that may come up?
You bet. And I will just
Awesome.
towards the end, I'll bring up the contact as well. And I will put in my email, so in the chat as well.
Great. And I just will follow up again with Nisa. She left, I guess we missed her question earlier around Bill 22. From my reading the original document, I cannot find clear direction which limits the duration, length of stay within stabilization settings, with discharge being reliant on the physician's assessment of the young person's stability. With the current tainted drug supply with benzos, we see possibility for lengthy and complex withdrawal in those who use substances. And then the question, are there limits that I'm not seeing, or is it really at the discretion of physicians? That's a good question.
It's a great question. So the idea around stabilization care was 48 hours, and then a second physician could recertify in essence for up to 7 days. So there was a limit. But if, for example, and we see this, physicians are looking at, or psychiatrists are looking at the Mental Health Act, and they can, so I think this gets to your point, within the Mental Health Act writ large, Bill 22 was going to amend a part of the Mental Health Act, but when we take a look at the Mental Health Act writ large, there is no limitation so that it can be recertified over and over again. So there are time limits. It's like, you know, after a certain period of time, you know, you have to get another psychiatrist or physician to recertify. You have to create opportunities for review. So 1 month, 3 months, 6 months, et cetera. So, so it's kind of, it's an interesting piece, because stabilization was for 48 hours or up to 7 days, but then you can still, it is possible to use the Mental Health Act to kind of detain for a much longer period of time. So that's probably why it was not clear. And the current tainted drug supply with benzos, yes. And of course, so many things that are not responding to naloxone. Lengthy and complex withdrawal in those who use substances. And that's why I say it's just unconscionable to me that we might have a 48-hour or a 7-day detention and then not have anything that would support that follow through, because the risk is just so heightened. And that's what Lisa Lapointe was so concerned about as well.
Great. And then Shay's left a question regarding a new systemic risk framework.
So yeah, hi folks. So I used to work, I actually was a service provider for about 2 years before I just couldn't anymore. So I have some experience, and because I was a harm reductionist before, I would get the really tricky kids, right? So my experience has been that the risk management framework for children's services across the board, and then therefore their service providers were even more risk avoidant, is even higher. So my question is recognizing that harm reduction systems methods will work with everyone, because you're not trying to control behavior so much as you're trying to support better health choices. Is there a way to look at the risk management frameworks that are out there now, which are, let's not hit the media, let's not get in trouble with children's services, let's not worry about the kids when they're AWOL, because that's not our responsibility. It's okay if they freeze to death because it didn't happen in our house. Is there a way to have these conversations more broadly? I don't think this is a BC only specific issue. I think this is national, and I think there's a bunch of us in harm reduction who would love to have these conversations, because the reality is these kids are better placed at home, and supports there would work. But even if, you know, even if they have to be taken into the system can't deal with these are not simple, easy kids. These are kids that deserve better, and kind of the general population. Yeah. Okay, I'm right. That was my question. Can we do this differently? Is there a way to have these conversations?
Yeah, I completely agree. And that's one of the things that I think it's so important that we keep speaking about this as we need to recognize that it's a complex problem, and that we have to wade into it and bring your perspectives as people who care deeply about this, and young people's perspectives, and those that are on the front lines, because no one has the answer. I canvassed all my colleagues across the country, and they're all struggling. And of course, every province and territory is manifesting itself differently. I would say BC is really struggling a tremendous amount because of what we're experiencing, the toxicity of the drug supply. So a couple of things. One is, when I released the report in 2018, I said harm reduction must be a part of the continuum. You have no idea how much pushback I got. I mean, they were just appalled that I would public, you know, I went on talk shows. It's like, and we've shifted. Like, there's a different kind of conversation. But I think we need to keep talking about harm reduction. As I said then, and I'll keep saying, it's like, I really want to keep this child alive. You know, and if that means that they're using because that's a coping mechanism, then for goodness sake, let's make sure that we've got a safe supply, that we've got supports around them, that they know that they're cared about, that they know that they can access supports or services, or have somebody on the end of the line that is not going to shame them or tell them they should just get their shit together, or pardon me, you know, all those kinds of things that we see. So harm reduction is a huge part of it. And can we do things differently? I think we have to do things differently. I don't think that the status quo is definitely not working for our young people and for the families. And so one of the things that I'm a little worried about is that Bill 22 ended up being quite polarizing. And it has resulted in us not leaning in to have some of the conversations we need to have, and to hold that space for the difficulties that we're all facing. And I had a beautiful conversation this morning. I wasn't expecting it to be a beautiful conversation, but it ended up being with physicians who I thought were going to tell me, you know, you're out to lunch, you should support this Bill 22. And they said, and we started with, let's just agree that we're trying to hold our children and our youth and our young adults at the center, and that we're trying to help them be as healthy as we possibly can make them. And we're going to have different views, and there is no playbook. So what are we going to do differently? And they acknowledged, you know, that the bill as it was written was not good enough. But everybody's afraid to have that conversation now. Everybody's afraid to lean in and say, what could be different? So we left the conversation by saying, maybe we just need to call everybody in And maybe that's a role that, you know, that we can, a few of us can come in and say, you know what, this is going to be messy. It's going to be uncomfortable. We don't know the answer, but can we, in a respectful way, center the well-being of people who use and address the things that are getting in the way of having a system that responds. So I don't know if that's helpful or fits, Shay, with what you're saying, but yeah, it breaks my heart.
Thank you. I'm just conscious of your time, Jennifer. We have a couple more questions here. Jan asks, what do you think of detaining 18-year-olds in the adult system? Because there is no space in the youth system. Then there are no services available in the adult system for after discharge. They are disconnected from the youth system they are familiar with. So
yes,
that.
Yeah. Very good point, Jan. And one of the things we noted in our detained report was how many young people were being, of that 17 and 18, they were putting in the adult system. And as I said earlier, the adult system was never designed for the young people in terms of where they're at developmentally and what's being called for. So we have talked a lot about we need to have that kind of youth and young adult, kind of a system that understands where young people are at developmentally and what they need, and not put them into the adult system. And of course we get the pushback. It's like, well, that's going to be expensive. It's like, well, it's expensive now, what we're dealing with. You know, so to kind of Shay's point, surely there's got to be some way we can do things differently. But it is of great concern to me that we're seeing 18-year-olds, 17, 18-year-olds being put into the adult serving system or into adult psychiatric units in hospitals and whatnot. It's just, you speak to young people, they're terrified.
Yeah. Here's another great question from Daniel. For youth who are not willing, ready, able to attend voluntary treatment, what might an ideal system of harm reduction services look like for youth? And how might we persuade desperate parents to embrace a harm reduction approach instead of involuntary or coercive approaches? Great,
Wow.
Good question.
Great question, Daniel. Wow. I don't know. I think, yeah, I've sat with many parents, and many of them, I understand it, and I've sat with many parents over many years, they just want one more night to know that their young person is safe, and I get that. And sometimes when we have the conversation, they know at some level that harm reduction will work better for their young person, but they're also afraid. So I don't know how look to this group, and maybe we have to have another conversation about this, but how is it that we can challenge that notion of abstinence-based approaches or not supporting harm reduction and looking more to the involuntary or coercive? And some of it is just understanding the desperation that people are experiencing and the uncertainty associated with the harm reduction or the voluntary approaches. Yeah, I don't know, Daniel, I'd love your insights. Yeah, so I'm just looking through. Ooh.
I was on mute. My dog is barking in the back.
Okay.
So just a comment from Tracy Letts. Many youth that are not in the system are slipping through the cracks, and there seems to be minimal to no supports or resources in place. Also, these are youth that will not utilize harm reduction supports due to stigma. Parents are also terrified of having their families brought to the attention of the ministry. How do we advocate for these invisible substance using youth? Good question.
Yes, absolutely. Such a good question. And I heard, again, speaking with the mom last night, she was so terrified. And in fact, spoke about the shame and the stigma, and not knowing how to ask for that help, and the fear. And we hear that all the time, especially if you're an Indigenous family or a family that's racialized or living in poverty, absolutely terrified of having anything to do with the child welfare system. So that separation of the child welfare system from mental health and substance use is, I think, important, because as soon as you go through that door of the ministry, then of course the fears are evoked. And yeah, I completely agree. That's why I say our data is just the tip of the iceberg, that there's a lot of invisibility for families and young people. And so I agree. And again, that's why I get to the voluntary supports that are at the discretion, that you don't have to be gate kept through to gain access to services and supports. And that we see that continuum, so that the family members or the parents can get the supports that they need all the way through to those intensive treatment and rehab and aftercare supports that are necessary. So I think that's why I keep pushing for that more robust system of care. It's going to require an infusion of money, but it's costing us a tremendous amount to do what we're doing right now, and it's not working. So I completely agree with you that we have cracks in the system, and there's very little for those families. That's why we have to keep pushing for a voluntary system of care.
Great.
Great, thank you.
Oh, sorry. Oh,
No,
thanks.
no, that was good.
Thanks, Tracy. From Trevor, thank you, Jennifer. On the topic of harm reduction, is your office involved in advocacy around making newer harm reduction policies inclusive of youth? For example, decriminalization in Vancouver and safe supply.
Mm-hmm. We haven't spoken out publicly about that, but it is one of the things that we're figuring out, where can we be most helpful. But certainly in the conversations with the ministry, made sure that the ministry is well aware that they're not going to get any pushback from me on those things. And sometimes, yeah, I'm just very mindful that the system is concerned about what the representative is going to say. So I'd much rather have these conversations with them quietly to say, you're on the right track when we do decrim, safe supply, pharmaceutical alternatives. And in fact, let's take a look at that and say, what are some of the things that are getting, because we've got some options now, but they aren't, we've got to get the system designed well to make sure that those alternatives are available. So that's an organizational challenge. So we've definitely made it clear that let's take a look at all we can around harm reduction. And some people ask me, like, how can you suggest that for children? And it's like, well, it doesn't matter what age you are, we still have a toxic drug supply. So it's going to affect children, youth, young adults, and older adults as well. So let's figure out what we can do to address this toxicity, because it's just causing so much harm.
Great.
Yeah.
How are you for time, Jennifer? Because
I'm fine.
I think we're near the end. Okay, maybe I think we have one last comment here, and then Leslie would like to say a few words. And so this is from Shirley. I support harm reduction, but I also believe that short-term involuntary hospitalization and treatment can save lives and reconnect families.
Yep.
I also support the need for wraparound services to be available. What we have now costs too much in lives and long-term interventions, which are ineffective. Yeah.
Completely agree.
Thank you.
Yeah, so again, it's not an either or. And I think that's one of the things media often says, puts you in this camp or that camp. And I have said, I've never said that there isn't a place perhaps for involuntary detention. We've got one case that we're dealing with right now that I think, that's one that I think we needed to do. We have a more coercive involuntary option, and we've, I think that there are cases that come to my attention that I think, we need to have this. But again, I think if we create an involuntary option, then if that's the only hammer that we've got, then that's the only tool we use. I don't know if I'm mixing my metaphors, but anyway, that sense of we've we've got to have more tools available in the toolkit so that we can discern what's going to be most helpful. And I continue to be worried because, so if we stabilize for 48 hours or 7 days, then what? And I think your point about long-term interventions, we don't really have good long-term accessible publicly funded care in British Columbia. We don't. So, and sometimes these are very, very deep issues and we need that longer term care, and we need to engage children, build that kind of relational sense of connection, and so that they feel like they're supported in their journey and they're going to be cared about. So that I just don't believe we should take rights away unless we're going to offer them something better and there's a better outcome. So yeah.
Thank you. Thank you. And on that note, I'm going to pass things over to Leslie for closing words, and to thank you so much, Jennifer, for your presentation today. Thank you.
Indeed, thank you so much. You've really given us the lay of the land. I think that's, many of us on this call we've read the basics on Bill 22, and they are intuitively abhorrent to us. Most of us just say no, no, no. I mean, I think we talked, Jennifer, at one time about, that the only good thing I can see coming out of it is the parents may have a few days of respite from worrying because they know their child is in care, but otherwise, there are probably 50 things that we could talk about that are dangerous and counterproductive about Bill 22. And I think it would be good for all of us to look deeply into it, to make our voices heard when it is the appropriate time, which I'm not sure what that is, Jennifer. Maybe you could answer that just for me. When and how do we put our voices, our opinions and our thoughts to government on, have we done that, or do we have to do it again on Bill 22? Sorry to throw one more question in.
No, it's a great question, and I think we need to. And I know that there were questions earlier about how do we do this. I think one of the things that concerns me is that we have created that this has become quite political.
Yes.
And that's never a good thing for public policy making at all, when you've got a highly politicized issue like this. And when you've got situations like, our little one, a 12-year-old dying, of course people are like, we need to do something now. So again, let's be thoughtful about good public policy. And I think that requires us to lean in and to be prepared. And it concerns me that there haven't been some of the consultations that I would have hoped would have occurred post Bill 22. So I think if I can suggest asking and saying, we cannot wait to have these consultations. And, we have some thoughts, we have some ideas. At the very least, we want to have a good conversation about the issues that need to be addressed, and how we can pull together and have some collective purpose and moving forward. Because it worries me when we're all in our corners, because we're so much stronger together. And I do believe that we want the best for our young people and for all people who use and those who love them. And we've got a deep social problem, and it's multifaceted, and there's all sorts of different layers. So we can't just kind of go to our corners. We have to figure out, okay, we need to do this. So, I'm as a result of the conversation that I had this morning, I'm thinking, okay, well, what's our role and how can we facilitate some of that? Or how can we all facilitate some of these things? Yeah, but that's my worry, is that we don't have the conversations, or we go into our corners.
Right.
Yeah,
So,
and we need to push the ministry to have meaningful consultation, meaningful.
Right. And this is the Ministry of Mental Health and Addictions, or
the
Ministry of Health?
And both.
Both,
and
yeah.
children and families, because it's all interconnected.
Yeah, exactly. Yeah, sort of a question of if we were to write a letter, to whom would we address it? And I would say, Adrian Dix, Sheila Malcolmson. I'm not sure what's the name.
Mitzi
I'm not sure
Dean?
of the name. Hmm?
Mitzi Dean?
Yeah,
who's
Mitzi
Minister,
Dean.
yeah.
Anyway, and I really appreciate that perspective of that when we're in our corners, we're not having a dialogue. And so we happen to know we're right. So but on the other hand, to foster and to nurture dialogue is a really fine idea. I won't go on. I just want to thank everybody who's attending, as well as of course Jennifer Charlesworth. Thank you. I'm so glad we met, and I just value your words so much. So what else to say? Thank you, and let's all keep our minds on this issue, because we'll be seeing it, and we need to. Yeah, we at Mom Stop the Harm, generally, there's not too many in our membership that have what we could consider youth, but I was really glad, Jennifer, to hear you say up to 27, thinking about young people up to 27 years of age. But this brings up a whole lot of new ways to advocate. So we'll be thinking about it, and we'll keep in touch. So
yes, and please, the other thing for me is we're always trying to learn where things worked, or where there were little glimmers of light that made a difference. So I invite people to share with me their perspectives or the things that they've seen, because we also, there are some things that people have experienced that was helpful. So how do we amplify that? And Jan's comment, I just want to flag it, that every system produces the outcome it was designed to produce. So we do need to take a look at the ways in which we've designed our system, for sure. So thank you all for your time. And I hope that this isn't the last conversation. I'd love to come back and with a focus on all the information can learn from all of you and your own experience, and blessings to you all.
Thanks so much. Bye-bye. Bye, everyone.
Bye.